So SAV-IOL is a Swiss-based company. For those who know Switzerland, we are very close to the Léman Lake, very close to Lausanne, on the French-speaking part of Switzerland. And basically, we are manufacturing three types of product, or three products, let's say, three families. One family called Harmonis, it's an on-demand type of lens. And the other one called Eden, that has some diffractive element on it. But today we're going to focus mainly on Lucidis. And Lucidis is a refractive IOL with a very particular type of EDOF, extended depth of focus. And we can go, of course, through your questions. You can ask as many questions you want. We'll be able to try to answer all of those. And of course, part of that is how this EDOF is working. It's working through a PNDB. I'm very open to if there is a need to discuss about that and how that flies and how we reach those results. So feel free to just write your questions during the intervention of Dr. Mazhry and Dr. Latif, and we'll collect those as far as the webinar goes on and try to answer those. So basically, we are very happy today to have Dr. Mazhry and Dr. Latif presenting two different presentations. And meanwhile, we're going to have really an interaction session. And of course, again, feel free to ask questions, and we try to make our best to answer those. Just in terms of introduction for Dr. Mazhry and Dr. Latif. So Professor Mazhry is a consultant eye surgeon that I met in Lahore, Pakistan, 3 years ago. I remember that. He has the head of the ophthalmology department at Central Park Medical College and WAPDA Teaching Hospital complex in Lahore, Pakistan.
That's WAPDA.
I'm sorry?
WAPDA.
Ah, WAPDA.
It's WAPDA.
I was hesitating between the acronym and just the W.
No issues.
That's easier. You're also the chief consultant of the Acuity Eye Center. And Professor Mazhry is the member of the American Academy of Ophthalmology, European Society of Cataract and Refractive Surgery, and World Society of Pediatric Ophthalmology, just to name a few for sure. Dr. Latif, Professor Latif, is the head of the ophthalmology department at Ejaz Latif Medical College in Bahawalpur. Did I get that right? Hopefully. He is a certified trainer and examiner, convener at the FCPS2 Ophthalmology of College of Physician Surgeon in Pakistan, and has trained more than 100 eye specialists. Professor Latif specializes in cataract and refractive surgery and oculoplastics, and has introduced many innovative techniques in cataract and ptosis surgeries. So having said that, I'm handing over to Professor Mazhry to start and share the screen to get the first presentation.
Thank you, Max. Let me share my screen. And thank you again for nice introduction and nice words from your side. And we are here with an exciting webinar on the novel concept of EDOF, that is extended depth of focus. And as mentioned by Max, we have divided the discussion in two presentations, followed by Q&A session of 10 minutes each. And in the first presentation, I'm going to discuss the concepts of bi, tri, multi, and panfocality, neuroadaptation, and how does EDOF helps to attain multifocality. And in the second part, I'll be discussing my own experience and videos with Lucidis intraocular lens implantation and its results. And I always start my presentation with the recitation from Holy Quran. Bismillahir Rahmanir Rahim. Kayfa takfuruna billahi wa kuntum amwatan fa ahyakum summa yumitukum summa yuhyikum summa ilayhi turja'un. How can you disbelieve in Allah when you were lifeless, he brought you to the life. And then he will cause you to die, then he will bring you back to life, and then to him you will be returned. And my own presentations and input about phaco cataract is available at wofa.org, course, category, lens and cataract and phaco. And during the presentation, I will giving you little glimpses of my poetry. I write in Urdu, and we have translated an Urdu poem, Asrar-e Muhabbat, with the name of Mystery of Love. And after every section, you will have one stanza for change of taste. The agenda for today's discussion is, I have divided the discussion into 5 sections. The first one is the concept of lower and higher order abrasions and sphericity. Then we will be discussing the neuroadaptation and its relationship to dysphotopsias and focality of IOLs. Then it will be followed by discussion on bi, tri, multi, progressive focality, panfocality, and EDOF. And then we'll be looking into details. How does EDOF helps to attain multifocality, and what is instant focus technology? And the final section of this presentation will be patient selection and counseling, and that will be taken up by Professor Ejaz Latif at the end of the discussion. So here we come to the first section. Transparency of ocular media is very important, and then even if it is transparent, there are certain abrasions whenever we talk about an optical system. There are lower order abrasions we all know very well, and we all know very well how to deal with them. That is myopia, hyperopia, and astigmatism. Myopia and hyperopia are taken care of by accurate biometries, and astigmatism is taken care of recently by toric IOLs. Whereas higher order abrasions are the spherical abrasions like comma, trefoil, and they are largely dependent on the pupil size. Then they give rise to hazy night vision, loss of contrast, halos, and around the bright light sources. So these are the higher order abrasions. And once we talk about the eye's optical system, we have to take care of the lower order abrasions and higher order abrasions to give patient a good visual experience postoperatively. Lower order abrasions are about 90% of the population, they are there, and the higher order abrasions contribute 10% of the this incidence. And there is a concept of spherical abrasion. There is paraaxial ray parallel to the principal axis, and it comes to focus at a paraaxial focus like this. And once from periphery of the lens, this ray is focused in front of the paraaxial focus, this is positive spherical abrasion. And if this ray is focused behind the paraaxial focus, it is negative spherical abrasion. So here is a paraaxial focus, the ray focusing in front and ray focusing in behind. It gives rise to a little confusion and distortion, but we need to grasp the concept of depth of focus right from here. This range is depth of focus, as we will see in later slides, from positive spherical abrasion and negative spherical abrasion, along with fine sharp focus. And what we did was, with the introduction of aspheric IOLs, by modifying the curvature of the intraocular lens, of the peripheral part of the intraocular lens, we brought all the rays to a point focus. So by sacrificing the depth of focus, we gave a monofocal sharp focus to the patient. That was the introduction of aspheric IOLs. But the centration became very important. And then a little touch. This is a very important function once we start analyzing the intraocular lenses in terms of dysphotopsias, that is point spread function. It describes the response of an imaging or an optical system to a point source or a point object. And the result may be a very sharp point or distortions like this. And this is how the lenses are graded by modulation transfer function, which is based on point spread function. A good quality lens will produce the gratings as clear as object. Then there is fair quality lens, and then there is poor quality lens. And the concept of depth of focus, as I mentioned earlier, once you see the spherical abrasions, here you see there is a lens which is focused on a distant object. And it is, for example, it is an aspheric lens. So it has no option for near vision or intermediate vision. So depth of focus is lost. So if we are able to design a lens, or like the accommodation plays the role in natural eye, the near, intermediate, and the far, both are all are in focus, then we say this is depth of vision or depth of focus. So that ends the first session. And as I mentioned, here is mystery of love. This is how one loves, like dew sits softly on the green and the flowers during cold winter nights. That's how it goes. This is how one loves. So very soft concept of love is there in mystery of love. So we come to the second section, that is neuroadaptation and its relationship to dysphotopsias and focality of the IOLs. See, the first neuroadaptation I think a man experiences right after birth. See, the image perceived by the eye is upside down and the child starts crying. The brain immediately corrects it. So that's the first episode of neuroadaptation occurring right after birth, because the child is seeing the word upside down and the brain is correcting this with neuroadaptation. So neuroadaptation is a sensory adaptation, a gradual decrease over time in the responsiveness of the sensory system to a continuous stimulus. And very philosophical and interesting experiments have been done about visual neuroadaptation. A psychologist, George Stratton, conducted experiments by wearing reversing glasses for 21 hours in first experiment and for a week or so in second experiment. And ultimately, he was able to see the erect image again. So that's the flexibility of the human mind. And that's a flexibility which actually helps even with monofocal IOLs, even with simple spherical IOLs. That's our friend, which ultimately adopts, and with the help of the brain, the patient is able to see with any lens which we implant. Light and dark adaptation is another example of neuroadaptation. And spouse adaptation is between the spouse, husband and wife. That is also very important. So why neuroadaptation differs in different IOLs? Because retina is the first screen, or the photoreceptors are there to receive the image. The better image the retina will receive in terms of two dimensions, that is light and intensity. The image is conducted to the brain. Because the retina has perceived a crisp image with less distortions, less dysphotopsias, the brain has to do less work, less neuroadaptation, and thus better clarity. So the optics of the IOL are very crucial in terms of crispness of the image, and the side effects like dysphotopsias should be minimized. So that's the focus of all the modern IOL industry, to decrease the problems with intermediate and near vision and better give the patient better contrast sensitivity. We have to decrease the halos and glare. And then there is vaseline and waxy vision, and we have to take care of the astigmatism as well. Dysphotopsia means an unwanted image that the patient see after cataract surgery. Positive dysphotopsia is unwanted light, such as a streak or a starburst, flicker, fog, or haze. Negative dysphotopsia is a black line or a crescent in the far periphery of the lens. These are the different dysphotopic phenomena: glare, halo, flare, starburst, flash, streak. This is how one loves, like a beautiful bird fly on a colorful morning, circles around the flower. That's how it goes. We come to the section 3, by tri-multifocality and EDOF. You see, the monofocal lenses are there with single focus, then came the bifocal lenses, and really now the focus is on trifocality. And then there is a lens available with the name of panfocal, and then comes the EDOF. Refractive lenses have been discontinued because of their dysphotopsias and associated issues, and diffractive lenses are there in the market, like bifocal lenses, Acrysoft Restore and Technis, trifocal lenses, Fine VN, Etilisa, and Ray 1. Then the Alcon has got Panoptics, and recently Medicontour has come with trifocal Liberty, and Symphony lens is also there. And there various companies are coming with the EDOF technology as well. But problem with, here are the examples of these trifocal lenses. You see, all of them have got rings and steps. And these rings and steps lead to ultimately some loss of light and dysphotopsias, which gives rise to reduced depth of focus. Light energy is unevenly distributed, loss of contrast sensitivity, and dysphotopsias. EDOF design is a novel concept which, by inducing spherical abrasion, or like PNDB, by introducing a spherical button in the center of the lens, confers the depth of focus to the lens. As you can see, this is a novel concept of SAV-IOL. By introducing an aspheric button in the center of the lens, PNDB beam is provided, which is pseudo non-diffracting beam, which provides the depth of focus for near to intermediate range to the patient. And it's unique with SAV-IOL. And it gives the patient the more characteristic about this PNDB and depth of focus with SAV-IOLs is that it is aimed at near and intermediate vision. Then there is a concept of continuum of foci by controlled introduction of spherical abrasion by CFI. And we are still far from creating a perfect multifocal IOL. So how does EDOF helps to attain multifocality? See, it is a monofocal lens, only single focus. Then there is trifocal lens, but there are gaps left which trouble the patient in the end. And what does EDOF do? It, by extending the depth of focus, it gives patient wider spectrum and freedom for near to intermediate vision in case of Lucidis IOL. Like this. Here you see, this is the range of clear vision or focus to the patient provided by this concept of EDOF. And as you see, in normal diffraction beam, the beam comes to focus and then diverges. Whereas in this patented unique concept of pseudo non-diffracting beam, by controlled introduction of asphericity, you don't let the beam cross and you make it travel in such a fashion that there is a continuum of clear focus which provides the depth of focus or the range of clear vision to the patient. That is PNDB. Instant focus is a unique optical technology designed to replicate the accommodative function of the natural lens. And that is introduced by SAV-IOL. And pseudo non-diffracting beam we have already discussed. And here you can see again, a wavefront is here. There is an aspherical button. And here is the construction of the pseudo non-diffracting beam, that is PNDB, giving rise to extended depth of focus. And this is an animated concept of the same extended depth of focus by PNDB, pseudo non-diffracting beam. It is passing and a range of clear foci or the depth of focus is provided to the patient. So ultimately this leads to continuous vision from near to intermediate, and the gap between distant and near vision is reduced. It allows the patient to receive a full spectrum of vision. And we will go through this video quickly by David J. Apple, in which they are comparing the
three different trifocal lenses. The fine vision microwave, the Artelisa tree, the Acrosoph IQ Panoptix, and 4 EDOF lenses, the Minivel, the Lara, the Comfort lens from Oculentis, and the Symphony from J&J Vision. How can we visualize the optical pathways of all these lenses? For the experimental setup for the study, we used a green laser source, as you can see here, and we stained with fluorescent a water bath in order to visualize the optical pathway through the lenses with this green laser. Camera setup, video films as well as still pictures were assessed. Looking at the analysis, we used specific software for analyzing the light distribution to define the peaks of the near, intermediate, and distance, or the EDOF range of vision area. Here we see the Artelisa tree trifocal intraocular lens. The analysis showed two distinct foci for near and distance. The intermediate area where we can see a slight plateau, but still a distinct intermediate focus. Here we see the analysis of the Acrosoph IQ Panoptix. We can see here a predominant for the distance focus, a smaller focus for the near, and very close intermediate focus. The fine vision shows a similar image like the Panoptix. In the Minivel ready, we can see a good focus for the distance and a small plateau, which we call the EDOF area. The Artelara, you can clearly see the similarity to the trifocal lens. However, you can see a distance and near focus and a plateau area, which we will also describe as the EDOF range. These have shown the excellent visual outcome of all these lenses. But what about dysphotopsias and side effects? We've tested that with a dedicated software, a simulator for glare, halo, and other dysphotopsias. The patient can, on the screen, show what he perceives at night when he is in a typical situation driving a car. We compared the data from 60 patients with what we've seen in our experimental setup here. Here you see the Artelisa image and the according image in the simulator. It's a classical halo type. With a tripod F or the fine vision lens, you have a similar image. Let's see more a starburst type appearance. The differences among the trifocal intraocular lenses, especially in terms of the position.
So in this video, the message in this video and what I understand was that the depth of focus or the range of clear vision is there with EDOF technology, and the incidence of dysphotopsias is much less with EDOF lenses. And the final part of this discussion is patient selection, and that I leave to Professor Ejaz Latif.
Professor, we can't hear you. Okay. Try to find a solution for Dr. Latif.
Oh, sorry.
Now we can hear you. That's fine.
Okay. Is it okay? The voice quality is okay?
We can't just see your screen right now.
Just a minute.
Yeah, we see the screen. And so far we see Zoom, but we'll see. And after your slides, I believe.
Yes, yes. Now you see.
Can make it bigger.
Is it okay now?
Yeah, that's very fine.
So when we talk about
in my opinion, every patient who is having a good visual potential and he is affording as well, he should be given the choice to have this multifocal IOL. But at the same time, I will also emphasize that we should not overexcite the persons. If because we should not increase his expectation too high, and otherwise he may be having some maybe demoralized slightly if he has to wear some glasses. So we usually tell them that in 90% of the situations you will not be able to you will not require anything. Previous. But in 10% of the situations in life, you may need these glasses. And also we should avoid highly demanding patients. And if still the patient who is highly demanding and looks fussy, he is insisting for the IOL, multifocal IOL, we should have a written consent for any mild post-operative refraction. The best patients, in my experience, the best patients are the housewives, teachers, and sedentary persons and the office workers. And the worst patients are frequently the frequent night drivers. Mostly they are frequent night drivers who have to drive in routine during night. So it's better to avoid these cases. And this is the most important question which we are asking to the patient, whether they have to drive in night regularly or during night time or not. And if they are regular nighttime driver, we don't offer usually. And we ask them to have monofocal IOL so that they don't have glares. And in the IOL selections, while doing the IOL selection, we have to make sure that both eyes have the same mechanism of multifocality. Suppose if he is having this diffractive lens in one eye, the other eye should also have the same diffractive lens. Or if you give EDOF in the other, and there may be some difficulty in neuroadaptation because the mechanism is different in different eyes. So the patient may be feeling difficulties in neuroadaptation. And I've seen that patients are not satisfied when they are having different type of mechanism of multifocality in two eyes. And one important thing is that the monocular, if the patient is having monofocal lens in one eye, and he wants multifocal lens in the other eye, most of the persons or the eye specialists, they try to avoid that you have got a monofocal IOL in the previous eye and you should not have multifocal. But I have done this experience, and now I'm doing it regularly, that with this EDOF technology, I don't feel any problem. Patients are very happy. Those patients who have got monofocal IOL in one eye, they can have very easily, they can have multifocal IOL like of extended depth of focus, and they are very happy. Personally, I know many of them. They are young people, and they are having one in monofocal and the other multifocal IOL, and they are very happy. So you can offer the patients who has already got one monofocal IOL, you can offer multifocal IOL in the second eye. If the and it's better, we should have the EDOF technology and not the refractive. During surgery, I would like to say some special things which are to be done. And the one thing is the rexes. The rexes should be smaller. If the lens size is 6.5, it should not be more than 5.5. And it should overhang the margin of the lens all around, so that it will keep the IOL centered, and it will also prevent PCO. So it will something better. And the IOL centration during surgeries we must make it central, but while making the IOL center, we should also avoid to touch the instruments like dialer to the central part, especially of the optic, especially the central zone or the rings. The instrument should not be touched to that, otherwise there may be problem of glare and flare. And I would also like to finish the second part of my presentation now, because it's only few slides about the post-op counseling of the unhappy patient. There are some patients which are unhappy post-operatively. The VN does not come to their expectation. So we have to mention them about the neuroadaptation. We should counsel them, and we should tell them that it will take few weeks, maybe 6 weeks to 6 months even, for the neuroadaptation, because it's a new mechanism of seeing, and your brain will soon adopt it. And if we can also tell them that the best VN you will enjoy will be when you have the VN in the second eye, same VN or same mechanism of the VN in the other eye. So it's better to have multifocal IOL in the second eye, and the bilateral multifocal IOL much happier than unilateral, because of the depth of the focus, and because both eyes, when he can open both eyes, if there is mild post-op refraction, this will be covered. And if the patient is still hypermetropic, or say he's having post-operative 0.5 and he's not happy with the near VN, he's okay with the far VN, then we should make the second eye slightly myopic, maybe 0.5 diopter myopia, post-operative myopia will work. And when he will open both eyes after the surgery, he will be happy. Mostly they are very happy patient after the surgery. So one thing which I want to mention is the comparison of the results. In the last 2 years, we have done almost 500 multifocal IOLs, and out of them, this ratio is 300 to 200 with the EDOF lenses are 200, and the more are diffractive lenses are more. So, but dysphotopsia is more in refractive lenses. It's at least 35% patient are complaining, but with the EDOF or Lucidis, only 15% are having dysphotopsia. And for the near vision satisfaction, diffractive are more satisfied. By the way, it's about 90% are happy, and with the Lucidis, 85% are happy. And overall satisfaction of the patient with the far and distant near vision, and the quality of the vision is better in the EDOF or Lucidis, especially the because it's a aspheric Lucidis EDOF, and 90% of the patients are very happy. And there are many young patients who are driving regularly, and they are very happy with the outcome with the EDOF, and we are using only the Lucidis EDOF. Now, this is what we used to see very commonly when we entered in the field of ophthalmology about 30 years ago. This is what we used to see all around in third world, because the phakic patients and they were wearing plus 10 glasses, and they were very happy when they used to go back their home after camp surgery, and with 10 plus 10 glasses they used to see their cattle grazing in the field. So they were very happy. But now the things have changed. Now the patient want to see each and everything, from a leaf of a star to the clouds in the sky, everything clearly without any glasses. So we have got the multifocal, but for this, the uh, VL quality has raised from 6 by Buffalo to 6 by 6 and N6 next day. The patient wants 6 by 6 and N6 next day for without any glass. So, but in the meantime, we have got the multifocality, but in the meantime, we have left the asphericity. But here, with this new invention of EDOF technology, we are using this lens, and we are providing both asphericity and multifocality. And with this technology, the patient can see very clearly, have crystal clear vision from near to far, with all contrast and natural colors, with the help of this EDOF technology, latest technology, which is called the instant focus technology. Thank you so much.
Well, thanks very much, Dr. Latif. Thanks very much, Professor Mazhry. I mean, it was two different presentations that are really complementary to each other, and thanks for that. Maybe we can go into a kind of a pause or slight discussions. First of all, thanks to Professor Masri for the parallel with the poetry, because that always helped. A little bit of a step back, because we are doing all those things very technical that you have very well described. But at the end of the day, I mean, you're right. What is important in life is much more easier. So thanks for that. Coming back to the theoretical aspect of it, it's important to really emphasize that the Lucidis has a pure refractive design, and consequently, the numbers you show on the dysphotopsia effect for the patient is self-explanatory. We should have 0% in terms of dysphotopsia because there is no rings at all. And the beauty of the PNDB created that Professor Mazhry described is that this slope, the slope that you see on the bump, is really calculated as creating interferences by refraction only. And that's key because all the other competitors, except one that we have seen in your video, Professor Masri, but they are creating an EDOF with diffraction. And of course, with the dysphotopsia that are associated with that. So I think it's very important to mention that the dysphotopsia can happen because you can always feel from a clinical perspective dysphotopsia, but it's not coming from the technology.
Right, I agree to it. And in the final presentation, we're going to look in detail. And in my study, I have used about 150 IOLs of this Lucidis and few IOLs with Eden, which is premium trifocal from SAV-IOL. And I have used Lucidis Toric as well. But I agree to Max that there is no complaint of dysphotopsia whatsoever. The spectacle dependency, or we are making the patient less spectacle dependent, and even with very costly premium lens, I don't promise now spectacle independence to the patients. That's our experience, which we have learned over time, because all the lenses, even top end trifocals from any company, still for very fine vision, sometimes some patients do need specs. So dysphotopsia is the thing which I agree to Max, and that's a real commendable thing that Lucidis can be recommended to anybody who understands. And the beauty with this lens is that it is monofocal premium, and mostly the patients get reimbursement being monofocal lens. So that's the beauty with this lens, that it can be, it competes the monofocal IOLs, and by its unique concept of instant focus and PNDB, it confers and imparts useful near and intermediate vision to the patient. I think let's move to our final presentation.
Mhm. Maybe before we just get into your next presentation, Professor Mazhry, just maybe an open discussion real quick on the mix and match type of thing. Professor Latif, you mentioned that it's sometimes better to have the same type of IOLs in the two eyes, whereas in other countries or talking with other doctors, we had different feedback saying, you know, it's better to put the EDOF in the dominant eye and the monofocal on the other eye, or the reverse. So from your perspective, Professor Mazhry, Professor Latif, what is best?
Yeah, when the one eye is monofocal, then you can do anything. You can implant this EDOF, definitely. There is no problem. But if he's having a diffractive lens in the other eye, then if we put some other mechanism of multifocality like EDOF, I have practically seen that patient is not satisfied because the both VNs are different and there is difficulty for neuroadaptation because the mechanism is different. I have practically seen this. So when there is a monofocal patient, patient has a monofocal lens in one eye, then we can offer, very simply, we can offer that you can have a multifocal type of lens like EDOF in the other eye, and the patient are very happy. They are very close to me, many of them, and they are around me, and I always asking them whether they are happy or they are having some dysphotopsia, but they are so happy that no, we can see at least our mobile or our devices, that who is calling us without glasses and taking out glasses from our pocket. So quite 50% of the times in their life or situations, they can manage without glasses, even in the other eye, which was monofocal. So I am not saying that we should not put the EDOF IOL in the other eye who is having monofocal. So in monofocal, there's no problem. But if he's having diffractive lens and here you are going to another technology, then it may be difficult. So those who are having diffractive lens in the other eye, they are very happy when diffractive lens of the same style or same companies put in the lens in their other eye. So they are having binocular vision and enjoying the vision. But I've recently asked a person after maybe last week, I just asked this person. She was a very learned lady, and she had diffractive lens in one eye, and in one eye she was having this one EDOF. Both were done by me. So I just asked, because there was different technology. So I asked her, how is she feeling? She was, honestly, she was much better feeling with the EDOF lens, but she was not happy, but both eyes were open. So she could not be able to fuse. Maybe this is the reason, and there's some problem with the neuroadaptation. That's why I recommended in monofocal, you can go ahead. But if he's got a diffractive lens or other type of lens in the other eye, then it's better to have the same.
That helps. Professor Mazhry, do you have the same type of?
I had a few years ago, I had a paper in ESCRS with the name of Mixing and Matching Multifocal Rainer IOLs. And that was an interesting study of about 50 IOLs. And I had all the kinds of mix and match in that study, mixing it with monofocal, mixing it with some other multifocal, and mixing the lens with monofocal eye and phakic patients as well. For example, there is a traumatic lens, cataract or a Fuchs kind of unilateral cataract. Still, you can consider if the macular function and other things are good, we can implant the IOL. To me, the real thing is explanation and counseling. If you have explained the patient well that you have monofocal intraocular lens in one eye and you are going to have EDOF or a multifocal lens in your other eye, the only thing is that the patient needs to understand that the ideal scenario is having the EDOF in both eyes. But short of that, the patient will benefit from the depth of focus and the range of vision. But not to compare to that patient who has the same lens in both of his or her eyes. If we have explained it well, then mixing and matching is not an issue. And as I am going to share my study of 50 IOLs, which is accepted by Asia Pacific Academy of Ophthalmology for their virtual meeting as well. So there is mixing and matching the lenses in that study as well. We can
So,
again
sorry. So, do you mix these diffractive with the EDOF in one patient?
any lens can be mixed if we have explained the patient. Because one patient was here with Rayner bifocal in one eye, and the Rayner was no more available. So I explained that we can go for either Lucidis this Eden trifocal or Lucidis monofocal with EDOF. The patient agreed for Lucidis. I implanted, and I just told him that you may take a little while, because neuroadaptation, as I have explained with some historical perspective as well, is a more kind of psychophysical phenomena. If we keep on reassuring the patient, and the patient, we make the patient mentally strong by our explanations and taking him in confidence, then probably this phase goes easily, because I've already told him that this lens is no more available, and we are going to implant an EDOF lens with depth of focus. The patient was happy. Though, as Professor Ejaz said, the patient was happier with EDOF, because the beauty with this EDOF technology is definitely less dysphotopsias and less side effects in terms of compromised or waxy vision or whatsoever.
Absolutely. Thanks. I mean, that's really key. And I like the parallel that you make with the neuroadaptation and the burst, because that's really certainly the biggest neuroadaptation. Why don't we have one question, but we're going to take it at the end. Why don't we go right now with your slide, with the second presentation, Professor Mazhry, with regards to your results for Lucidis. Then we can take the questions afterwards, if you would.
Just sharing my slides.
Yep.
And in this presentation, we are going to discuss this Lucidis lens in detail. That is, experience with Lucidis EDOF IOLs. So the agenda of this discussion is, first I'll be explaining what makes Lucidis a great lens, as we discussed in the end of the previous discussion as well. Then there will be Lucidis IOL implantation videos, one with Rayner disposable injector and one with Contamac in disposable injector. And then I'll be sharing the highlights of the Lucidis IOL study. And in the end, I will be summarizing the webinar. And again, how do you love? This is how one loves, like a flower in a vale, among the dancing blooms, a beetle bombinates. Like in a flower vale, among the dancing blooms, a beetle bombinates. That's how it goes. That's how one loves. That is mysteries of love. What makes Lucidis a great lens in our practice? These are the common characteristics to all the SAV-IOLs, that they are hydrophilic lenses with 6 millimeter overall diameter, and this is a +5 to +30 range. And they can be injected with, I have seen that about ±3 millimeter of the incision is good for injection of these lenses. And to my feeling personally, I feel that the lens is relatively bulky as compared to other lenses, or little difficult to fold, but that imparts it excellent centration and final fixation in the capsular bag. And that goes in its favor once we are talking about the toric IOLs, because this lens is once implanted in the capsular bag is absolutely fixed. There is very little chance of unwanted rotation of this Lucidis design. And what makes Lucidis a great lens? Because it is affordable, monofocal lens with EDOF technology and with that PNDB and instant focus, which confers it some intermediate and near vision, and it makes the patient less dependent on glasses. And because of its beauty of combining economy with quality, we can offer to greater range of patients. And especially in developing world like ours, I think it's all over the world. Economy really matters these days. So this is a great addition to the IOL industry, this Lucidis lens, monofocal premium lens with induced aspheric button in the center, imparting it PNDB, instant focus, and near vision. And we have already explained this slide that aspheric button is here in the center. Then this is a optic of the lens, and a pseudo non-diffracting beam is created, which gives patient a range of clear focus and imparts depth of focus for near and intermediate vision. And the second beauty with this lens is, and the inventor of this lens is that he has aimed this EDOF at near and intermediate distance. There are some other EDOF lenses which have aimed it at between distant focus and intermediate focus. I think this idea of aiming it at near and intermediate distance makes it more useful, because we understand that there are going to be gaps in the kind of clear vision range of the patient. But if we fill the near and intermediate gap, the happiness factor increases. That's the more useful vision. As you can see, it imparts a range of clear vision between in the near and intermediate range. This is as we have already seen, it's a hydrophilic lens, EDOF based on pseudo non-diffracting beam technology. It provides quite a good range from +5 to 30 diopters. Is the aspheric button in the center, and then there are the refractive surface for far vision. And this introduction of asphericity in the center makes it a little pupil dependent. So the patient with micro pupils or very small pupils may not benefit from this technology. So with this, we end the first section, what makes the Lucidis a great lens in our practice. So this is how one loves, like the fragrance of life, secretly and slowly spreads into the air. That's how it goes. This is how one loves. And with this, we move to section 2, that is the Lucidis IOL implantation videos. In the first video, we are going to use Rayner disposable injector. The capsular bag is cleaned. As we routinely do, the successful phaco has been performed with 2.75 millimeter in CN. The lens is loaded in Rayner disposable injector. And I always advise, keep your anterior chamber very deep, full with viscoelastic, and keep on watching the delivery of the intraocular lens till the very end, because this is a relatively bulky lens and its unique haptic design. The prongs of the haptics have a wider distance between them. So you have to be really watchful that the leading haptic goes right into the bag, because if you are stuck, accidentally implant in sulcus, this wider haptic design sometimes will be troubling you to reposition it into the bag. But if you are stuck in that situation, I would advise keep the chamber deep. Never let your anterior chamber get shallow during intraocular lens manipulation with any other IOL, and especially Lucidis. So the second video is with contact injector.
Today, I'm going to discuss phaco with Lucidis intraocular lens implantation using Contamac Ergo Touch injector. It is a relatively soft cataract. And we proceed with frequency at 12 o'clock position because this is a steeper meridian in this case, and the patient carries about 1 diopter of astigmatism, steeper axis being 90 degrees. The anterior chamber is filled with viscoelastic material, and a little viscoelastic is spread over the corneal surface. Then the two side port incisions are fashioned on both sides of the phacoincision. Because my preference is bimanual irrigation aspiration, that's why I prefer two incisions. The 27 gauge 60-tone needle enters from the side port incision. The capsulotomy is being completed. Tongue of the capsule is everted, and then all the rest of the pull push force is applied on everted anterior capsule. Little by little in each quadrant, which is followed by hydro delineation. And there is yellow ring sign. The phaco handpiece comes into the picture. It's off to cataract, not possible. So after emulsification of the irrigation aspiration and polishing of the capsule is performed, the anterior chamber is filled with viscoelastic material. And here comes the EDOF IOL with extended depth of focus. A beautiful lens in our experience, which combines the quality with economy and gives quite good spectacle independence to most of the patients with its extended depth of focus feature. The lens is applied in blister pack recently, along with Contamac Ergo Touch injector. Presently, being an era of preloaded IOLs, this appears to be a little cumbersome to me. The assistant has handed over the cartridge, and now the blister pack is open, and the lens is being handed over to me with the help of McPherson's forceps. I place the lens inside the cartridge under microscope and pressing it into the cartridge tunnel with McPherson forceps. We gently close the cartridge so that there is no haptic or optic catch. Then the cartridge is parked in the plunger. And interestingly, this beautifully designed injector lacks one interesting feature, that is locking of the cartridge. Once the assembly is complete, the plunger is moved in forward direction so that the lens is placed in the pre-delivery position. Now it's ready. I have used 3.2 millimeter incision here. It just snugly goes into the eye, and a very slow injection process is my priority. And I keep on watching the delivery of the lens till the last minute. As the haptic is opening up, I'm very slow in the process because this lens beautifully centers because of its atypical wider haptic design, but you need to be careful while injecting it so that you don't entangle the margin of the anterior capsule into the leading haptic. And my priority generally is to implant the trailing haptic into the bag with the help of injector by dipping its tip. But in this case, it was delivered anterior to the capsule. Thus, I used Sil's T-hook to position the lens in 3 and 9 o'clock positions. And again, bimanual irrigation aspiration comes into the picture. Close the self-sieving the procedure.
So this was section 2. We come to section 3, that is the study highlights now. The purpose of this study was to evaluate the Lucidis EDOF IOL for safety and post-op results in terms of intraoperative behavior, improvement in quality of vision, and it was carried out at Wabda Teaching Hospital Complex, Lahore. Prospective study, 50 eyes of 40 patients. And Lucidis EDOF IOL was implanted for 2 years from November 2017 to October 2019. The patients with intraoperative complications were excluded from the study, like RIP and rent. The postoperative assessment was on day 1, 1 week, 6 months, and yearly thereon. Quality of life was assessed by interviewing the patient at least 3 months postoperatively. Minimum follow-up was 6 months and ranged from 6 to 24 months. All 50 eyes had smooth phaco and smooth injection of IOL except one patient, which the IOL got stuck into the cartridge and that was excluded from the study. Only 15 patients had bilateral implantation. That's what the mixing and matching I was mentioning. Only 15 patients in our study had bilateral implantation. Rest were mix and match. 20 patients had uniocular lucidis and 1 patient had refractive Rainer bifocal in the other eye. 4 patients had monofocal IOL in other eye, and the 20 patients with uniocular lucidis were phakic in other eye, and due to some reason, they were not ready for the other cataract operation very soon. 1 patient was there with the only eye, and the other were phakic. None of the patients complained of nighttime dysphotopsia and glare. That's a very important finding, that none of the patients complained of nighttime photopsia and glare. 1 IOL haptic got stuck, and as I already mentioned, that was excluded from the study. And unluckily, that patient also got the TC rent. So conclusion, the Lucidis EDOF technology IOL appears safe and economical and effective option for phaco-IOL surgery for the patients wanting less spectacle dependence after phaco-cataract surgery. However, studies with bigger sample size and longer follow-up are needed to establish this fact. Interestingly, EDOF technology appears to minimize the risk of nighttime photopsia and glare. The compatibility of preloaded IOL injection system is the need of the hour for safe intraoperative manipulation and implantation of the IOL. And that's what I always keep on discussing with Max, that we need preloaded IOL system, we need a compatible injector. But I understand that technology is entirely different and it is as good to invest as IOL industry itself. So this is how one loves. Like a gray flying cloud shows up and shadows the blazing bright sun. That's how it goes. That's how one loves. So webinar summary. We, in the first part of our discussion, we discussed the concept of lower and higher order abrasions, sphericity, spherical abrasions, and the depth of focus. And then the discussion was followed with the philosophical concept of neuroadaptation and its relationship to dysphotopsia and focality of the IOLs. And then we watched a video where the different IOLs were compared in terms of their real outcomes and dysphotopsias. And we noticed that the EDOF technology definitely carries an edge over all modern diffractive IOLs. And as I have mentioned in the study, the Lucidis IOL especially with introduction of this spheric button has almost zero risk of dysphotopsia. How does EDOF helps to attain multifocality was discussed. Instant focus technology, which is very special to SAV-IOLs, was explained, and Professor Ejaz Latif was here with patient selection and counseling. And in the second part of the discussion, we had discussion about what makes the Lucidis a great lens. That's the beauty of combining economy with quality. And being a monofocal lens, the most we can offer it to the wider range of the populations, the affordability increases. Then we had the implementation videos of the Lucidis IOL, and finally we had shared the Lucidis study highlights. And to conclude, EDOF with PNDB and instant focus concept appears greatly helpful in extending depth of focus, minimizing the spectacle dependence, and minimizing dysphotopsias. Lucidis IOL, a premium monofocal with EDOF, combines economy with quality in phaco-cataract surgery. So as Professor Ejaz said, under promise, overachieve, and then celebrate your success in phaco-cataract surgery. Thank you very much for your attention. And again, how one loves. This is how one loves. Like a candle burns, remembering someone lost, shedding tears all night long. That's how it goes. That's how one loves. Like Lucidis IOL gently provides range of depth of focus to the patients. Thank you.
Thanks a lot, Professor Mazhry. That's really brilliant. We really like the way you presented that, both for the surgery, the video, and of course the parallel always with what's important in life. So thanks for that. Thanks for Professor Latif as well. Couple of questions. I have already answered to one, which is related to the point you just have pointed out a couple of minutes ago with regards to the preloaded version of the IOL, but the first one was a couple of minutes ago with regards to the post-operative training. It's a question from Aram. Is there any post-operative training for the patient to enhance or accelerate the neuroadaptation? What would be your take on that, Professor Latif, Professor Mazhry? What do you think?
Can you repeat the question for me?
Yeah, the question is really, what's the training? Is there any training post-operative for the patient to accelerate the neuroadaptation?
I don't know about any training, but only explanation needs to be quite good enough. And as I mentioned in my last slide, in a very light mood, under promise, overachieve, and then celebrate your success. So that's the key to success in premium IOL practice. Don't overpromise. Don't promise that there will be no need of spectacles. And let the patient understand that whatever we are offering, whether we are offering EDOF, whether we are offering Eden trifocal, whether we are offering Lucidis toric, we are offering it in the interest of the patient. And the patient is the one who is going to spend and decide what suits him or her. And I very, very clearly explain that you will need sometime any kind of lens implanted in terms of neuroadaptation. So there is no specific training, only explanation and counseling is important, and then making the patient responsible for the decision he takes or she takes.
Absolutely. And I got the same thing, because every time we discuss with patient, the patient expectation before surgery discussion is key. If you say you may see or you may read 50% or you may have some spectacle from time to time, if at the end there is no spectacle dependency, I mean, the patient will have a very good surprise. That's far better than the reverse, that's for sure. Thanks for that.
Right.
Kind of a last question, which is really an open one, a question between hydrophobic or hydrophilic. I had these questions many, many times, but maybe Dr. Latif or Professor Mazhry. The question is really, what would be the preference from your side, if there is any, in terms of platform of material?
The hydrophobic IOLs and hydrophilic IOLs, it's a long story. And we are not that concerned or that kind of convinced now about this hydrophobic and hydrophilic nature of the IOL is the only thing which matters. As by Apple, there was a great study about the square edge technology. And then the whole concern, which was mainly there between hydrophobic and hydrophilic IOLs, was the incidence of capsular opacification. Now we understand there are more factors which lead to capsular opacification, like the design of the IOL, like presence of the square edge all around the lens. And then we agree to it that there is something in the material as well. But the hydrophilic nature of the lens makes it friendly in so many other terms and design that the only incidence of PCO, in my opinion, doesn't matter that we should be thinking about anything about necessarily needs to be hydrophobic in nature. No, we have enough experience with hydrophobic and hydrophilic lenses, and the results are equally good. And if it is a good quality hydrophilic lens, then there is no incidence of calcification and other things. Though with the relatively lesser quality hydrophilic lenses, we have seen the lens calcification and deposits inside the lens, but the incidence is very rare.
Well, I will also like to respond this question. Usually, I keep the hydrophilic phobic IOLs for these persons who are having some inflammation in the eye, like mild uveitis, or they are having posterior synecdoche due to this. So I've seen that hydrophilic lenses are much better. Hydrophobic lenses perform much better, and there is less deposition of the pigment on surface of these IOLs. Otherwise, in normal persons, hydrophobic is easy to install and is softer lens, softer material. And usually, in normal cases, I don't feel any difficulty or any difference in the results.
But I would like Max input as well. Your input.
I think it's very similar to you guys, because it looks like hydrophobic versus hydrophilic is like a kind of an old debate, because at the end of the day, what matters is the patient comfort and what you can just get out of that surgery if we step back a little bit. That comes back to the different poetry you spread the presentation with. All these technological aspects, we love it. I do love it. We have developed Lucidis with passion, but at the end of the day, regardless of the technology behind the scene, what matters is the patient, and the outcome you get with that.
Agreed. That's right.
In hydrophobic, it's good. If it's in hydrophilic, it's good as well. So what? What is the important thing is really to have the best compromise we can get to the patient for him to recover the vision.
Yeah.
More technically, I would say there are pros and cons. You have very well summarized that. I don't want to go over that. But I think what's important is before surgery, the patient has to be aware of those potential adverse effects for the hydrophilic hydrophobic and the benefit he can get out of that. It's always a trade, unfortunately. There is no magic solution. Yeah. So that would be my take on there.
If you have some time, can I ask one question from Max?
Sure.
Hello. So can you tell us or guide us about the overall size of the lens, like this 10.8 and 12.4? So is there any cutoff line where should we use the larger lens and where should we use the smaller lens? Because in hyperometropic eyes, especially when I used to have 12.4 in the beginning. So in those cases, I used to have some difficulties for the insertion of the second haptic, trailing haptic, and there was some folding of the haptic inwards. So now I usually do 12.4 for less than 20, and for 20 and above I use 10.6 or 10.8. So can you guide us something better?
That's a good question. What we get in terms of feedback from different doctors is that above 18, you have to also prefer 10.8. I would say 18 more than 20, and below that, for sure, 12.4 will be recommended. However, at the end of the day, I think it's really dictated by the capsule bag size and what you really think is going to be suitable the best. This 18 threshold between 10.8 above or 12.4 before is really kind of a example. You said 20, maybe it's relevant as well. So that's what we observed.
The viability after a plus 20 diopter at the age of 20.
I'm sorry?
20 by 20, I mean plus 20 diopter biometry. If it is more than 20 diopter of biometry, that's hyperemetropic eyes, then I use 10.4, and below that I use 12. Isn't the age?
That's right. That's right. As I said, we observed a threshold more around the 18D. And below 18D, they consider, some people are considering, okay, we're going to use the 12.4. But at the end, it's very similar, 18 or 20. The threshold is more or less the same. Huh? We had a question from Maria about the near vision calculation. I think that was shown, or generally speaking, was it used with a Jaeger scale? Was it the case?
We use the regular Neo-VN chart to document this. And secondly, we had a questionnaire which we asked the patient at least 3 months post-operatively, like reading newspaper and watching television. So these were the 2 criteria which we used for the practicality and driving, if the patient is driving.
Yeah.
So this was the criteria which we used.
Well, thank you. Thanks a lot. I'm not reading any more questions. Of course, if someone was just to write something real quick. I know we are a little bit just completely out of schedule, but I think it was really interesting and really passionate discussing with you guys. Okay, we had a last question. How to manage the bulky leading haptic?
Bulky leading haptic. That's the key. You see, I have experienced this problem. Keep your anterior chamber deep. Never let your anterior chamber collapse. That's a key to success with this Lucidis IOL implantation. And never shoot the lens. Be very slow with your IOL injection and keep on watching the leading haptic is delivered into the bag. And if on one's kind of blue day or whatever you call it, you are once a while you are stuck and the leading haptic doesn't go into the bag, no problem. Take a deep breath, relax, and fill the anterior chamber again with viscoelastic. Get the iris well dilated, this pupil, and then you can manipulate the lens with the help of Sinskey hook or a bimanual handling. You can again reposition the lens into the bag. But with the Lucidis IOL, I understand the concern of the doctor and the surgeon, because it is more important for this lens particularly because of its wider haptic design that the leading haptic goes right into the bag. You need to be slow, keep the chamber deep, then it is not an issue.
Yeah, I think that's key, and thanks for that, because the will be very slow.
Whenever the leading haptic is released out of the bag, it goes out of the bag or in the sulcus or in front of the iris. My suggestion is we should make a deep anterior chamber, refill it, and reinflate the capsular bag, and simply don't try to pull it out of the sulcus with the help of a Sinski hook or something like that, because it may damage the zonules. So in such cases, refill it, reinflate the capsular bag, and just press the most peripheral part of the optic downwards, and the whole of the haptic will go ultimately into the capsular bag. It's very easy. So don't panic and don't try to pull the most peripheral part out of the sulcus, because it may damage the zonules. It's very easy. There is nothing, you can always put it down. Just relax and reconsider it. It will be okay. There's never a problem in the leading epic.
I think that's key as well. That if we have you have to get relaxed doing this operation and inject really slow, and that's key. And thanks for that as well, because especially for the 12.4, that remains diameter is of course pretty large, and that you may feel that a little bit bulky. That's totally understandable. But for those
in my study, all the lenses were 12.4.
right.
Yeah, I know.
Yeah.
And
So,
I think if you need to choose, you may consider wide to wide diameter is more important than refractive error itself. And the second thing, as you mentioned, the higher power, the more bulk the lens is going to get.
sure.
So that may be ideal if we have both the inventories available. Then for higher powers, we may choose a lesser diameter. But even then, it becomes very important to implant it right into the bag, because otherwise the decentration will be an issue.
If you look at the volt height or the thickness of the lens when it's about 30 or 25, that's consequence. So I totally understand that. But for those who are with us, I mean, the advice for Professor Mazhry or from Professor Latif is really first to relax, and then second to inject slowly, and then do things very, very smoothly, and that's going to be fine. I think that's key to retain. Well, thanks a lot, Professor Mazhry. Thanks a lot, Professor Latif. Thanks to all of you around the world with all your questions. I think it was really passionate and really interesting to discuss about Lucidis and the way we operate, and especially with you guys in Pakistan. Pakistan is a lovely country. I have a very good memory of you guys there and all the team that I met there. I'm really looking forward when in the future we'll be able to travel again, to go back to Pakistan, whether it's in Lahore or elsewhere, and I would be happy to meet you again. So
I'm happy to host you
for today. Yeah, absolutely.
Thank you.
Thanks again for today, and for all of us listening to us, thanks a lot for the questions, and have a good day, and talk to you soon.
Thank you.
Thank you very much. We always enjoy interacting with you and always learn few things. Thanks a lot. Bye.
Thanks a lot. Bye-bye.
Bye.
Bye.
Bye.